We are very fortunate to have two student panels with us this evening. So I know that hopefully they can stay a little bit for the reception, although I know that they do have some studying that they have to do as well. So we try to be a little bit cognizant of what else they have to get ready for class tomorrow. So we're just going to start. This is our group of students to talk a little bit about their rural experiences. So I'm going to have you guys just start here with Laura and go down the line. The first thing I want you guys to answer or to say is your name, tell us where you're from, and tell us why you wanted to go into medicine.
So my name's Laura Thornquist. I was born and raised in Seattle. I actually attended the UW for my undergraduate. And I wanted to become a doctor after a lot of thought and trying a lot of different things for the flexibility, and I just really love the human body.
Thanks. Go ahead, Paul.
All right, I'm Paul Craven, originally from Port Angeles, Washington. The story for me getting into medicine is a very long one, so I'll kind of pare it down a bit. But I was originally a wildland firefighter for the National Park Service. Like I said, long story short, 2008, I had a friend of mine who was killed. And one of the findings from that was that it was a lot of medical problems led to his death. And so out of that, I asked the question, what can I do to kind of make things better for my community? And became an EMT, found out that I loved medicine, and next thing I knew, I was applying to med school. So.
Go ahead, Alex.
Hi, my name's Alex SnowMassara. I'm fourth-year medical student here. Interested in medicine, started out in IT. I worked with computers mostly and information technology, and loved solving problems and digging deep into complex things, but I felt like I was missing something, and that was kind of that human component. So I did some reevaluating and looked at medicine and kind of started down a different path. So that's what brought me here today.
My name's Galen Mills. I'm from Powell, Wyoming. A ways from here, and I really wanted to go into medicine, I guess, for a couple things. I grew up on a farm, and so my first exposure to medicine was on different animals, sheep and cows. So I really just from a young age really was fascinated by science and medicine with the animals. And then just growing up, I grew up in a Christian home, and I was able to see from my parents modeling in front of me, just taking care of other people and loving other people was really a fulfilling way to live life. And I just, I decided that, medicine is a great mixture of science and taking care of other people. So I thought it was a good fit for me.
So Laura, I know that you did RUOP last summer. So RUOP, again, is that 1 month between first and second year. So why don't you tell us a little bit about where you went and did your RUOP experience, and tell us a little bit about that community.
Sure, so I did RUOP in La Conner, Washington at the Swinomish Indian Tribal Community, which is an Indian Health Service clinic for any member of a nationally recognized tribe or the Swinomish people that the clinic directly serves. La Conner, you may have been, it's about an hour and 20 minutes north of Seattle. It's a really cute little tourist town, and then across the bridge, across the Swinomish Channel is the Indian community, so it's really eclectic and interesting. And I had a really great time. And I also did the triple I component of RUOP, which is an optional independent investigative inquiry. Every student has to complete one, and one of the ways you can do it is through a community health-based project in your RUOP. So that was a really excellent opportunity to sort of get to know a community and what needs could be met, and then try to mount a proposal for a community health project in those 4 weeks.
And what was your proposed project on?
So my project, I started a Reach Out and Read program, which is actually a national program that many people may have heard of or worked with, that introduces books to kids during the well child check visits between ages 6 months and 5 years, so before school, to try to get parents engaged in reading to their kids and sort of address the achievement gap that can happen between low-income communities and high-income communities. So they implemented it. Actually, it was great, and they're doing it now. So they're giving books to kids and educating families, and they've actually expanded to their tribal preschool, inviting those parents and kids and then giving books to even older kids. So it was great.
Great, thanks. So Paul, why don't you tell us a little bit about your trust community, where that is, and then talk a little bit about what you did in your trust community before you even got to medical school.
Okay. So my trust community is Port Townsend, so it's about 45-minute drive from where I grew up. So as part of the trust program, we do 3 big steps in our community. The first is before med school even starts, we go there for a week and get to explore. Then in between first and second year, we do our RUOP, as Laura was just describing. And then during our 3rd year for clerkships, we do our RITE, which I believe Alex will discuss later. But so for me, even before getting to start med school, I got to go and meet with the physicians who I was going to be working with for the next 4 years, get to hang out with them, get to know their practice, get to work with them in the clinic. And basically it felt like when med school actually started, I had already hit the ground running. Was getting exposed to working and learning new things, and it was a lot of fun and very exciting.
So tell us a little bit about how your RUOP experience went then, since you had already been to the community before. Do you think that made any difference for what you were able to do between first and second year?
Absolutely. So the advantage of having already been in the community is I didn't have to spend the first week finding out how to get around the hospital or which doctor do I need to talk to if this needs to get done. Everybody knew me. And as far as a training opportunity, what that led to is if the nurse saw something cool and felt that I would benefit, they would call me into the room. Or if the physician felt that I would get a better experience working with the social worker in the community, they would send me over there for the day. They already knew kind of my strengths and weaknesses, and so it led to a great experience.
Great, thanks. So Galen, I'm going to ask you kind of similar question. So I know you were actually in Wyoming for your trust experience. So maybe talk a little bit about your community, since you were basically at home, and what that was like for you to be kind of experiencing medicine in Powell, maybe on a different side than when you were young.
Yeah, so as I said, I grew up in Powell, and that's also where my my trust site is, which is also my RUOP. Sorry for the acronyms, but so that's where I was this last summer. It was a lot of fun. I think Paul was able to spend a week in his site before he went. I grew up in my site, so it was even kind of all those benefits, and then a few more benefits and a few awkward, I think, aspects, just because that's what medicine is like in a small town. And so it was great. I was able to spend a lot of time with a physician I actually shadowed in high school. It was just fun to be able to see that side of healthcare while taking care of a lot of people that I knew from growing up. I had a couple interesting encounters with some people that I knew were not comfortable with me in the room, but that's part of medical education, and so I had to learn to navigate that professionally, and I think I did. But yeah, it was a great experience. It's a long first year of being in the books and studying, and so RUOP is just a great opportunity to kind of get back into clinical side of medicine.
So Alex, since you're the eldest, if you will, as far as where you are in medical school right now of the 4 of you, can you talk a little bit about RITE and what your experience was like at your site, your trust site, and how that was to be in the community for that 6-month period of time?
Yeah, so I think RITE, Paul talked a little bit how RUOP was building on that first week he'd had, and then he was able to spend 4 more weeks a year later. RITE is either an 18 or 22-week program. I did the 22 weeks, which works out to be about 5 more months on that site. And it was really pretty amazing. Patients that I'd seen during the RUOP, I saw again kind of in follow-up visits, and I kind of already knew them, kind of knew about them a little bit. It was the first time I ever had that connection at any point during medical school. Essentially, all of my inpatient training was done in Seattle for the most part, prior to going to Port Townsend for the bulk of my outpatient training. And that freed me up to have just a lot of time to work consistently with the same faculty, to know the community well, and then to follow patients over a longer period of time than you might normally get the opportunity to do. So got to be with a mom, when she was 7 months, follow her through, deliver her baby, do the well child checks after delivery. And that was a pretty remarkable experience. It was not just, when you're doing your OB training, you might show up and get to know somebody very quickly, try to gain their trust and get to become a part of that birth team. Whereas you have more time to do it, which I think leads to a better training experience, at least a better patient experience in a lot of ways. So I enjoyed that aspect. And then the other piece of it is that because you're doing kind of family medicine and pediatrics and internal medicine, the outpatient portions all together, those kind of blend a little bit more naturally during the training process as they do kind of in real practice, I think, at least for what I want to go into, which is family medicine, which I thought was an outstanding training opportunity.
So my last question, which I'll just direct at all of you, and we can just start with Laura and go down the line here. So tell us about maybe one experience or one thing that you learned that is going to make a difference for you in your future practice because of these rural experiences.
Well, as I said, I grew up in Seattle. I grew up in Ballard and went to high school on Capitol Hill. I have not really had a rural experience, to be honest. And RUAP was really eye-opening for me. Even though LaConner is not the tiniest place in the world, and it's very near Anacortes and Mount Vernon, which are pretty large centers, I surprised myself with how much I enjoyed it, and especially the low-resource setting of the tribal clinic, where they've got one family practice doc, one PA, 2 nurses, and 2 MAs, and they're just like doing as much as they possibly can. So it was a really unique and different experience than what I'd had at being a patient here and shadowing in Seattle and not doing my preceptorships in Seattle. And it changed how I applied for my 3rd-year clerkship rotations. I definitely want to go more rural places, and we're going to find out in a couple of weeks where we get to go. We sort of rank things and then see what happens. And I definitely ranked more rural locations higher up than I expected when I started medical school, thinking, oh, I'm from Seattle, I'll stay in Seattle, this is great. So I definitely, that's probably the largest change for me. Not sure where I'll end up practicing, but just less afraid that it's boring or scary or lonely. It's actually really rewarding to be sort of outside of Seattle.
I think a big thing that I learned was being a physician in a rural community isn't a 9-to-5 thing. Even as the med student, I'd go to the grocery store and patients would recognize me and want to talk with me and ask me questions. And I loved that. That was fun. But it reiterated that, when the clock hits 5, I'm not done. I'm invested in this community. I'm part of this community. And I need to take an active approach to being involved, which I got to see carried out by the physicians I worked with. They were involved in the local schools. They were involved with the police department getting new training. They were invested in their community. It was their community. They weren't just taking care of a patient, they were taking care of a friend. And I love that. And that was a big thing I got to take away from my training so far.
Yeah, and I think one of the things that I learned quite a bit in my training in the rural part of Washington is something I've learned kind of throughout medical school as well, which is, in life we make a lot of assumptions about people we meet or what things are like, and as we're getting trained to become physicians, we start to realize that we can't make certain assumptions, and we have to kind of view all different aspects of life. And there are parts of rural Washington that just surprised me a lot in what I was exposed to. And so I think it was eye-opening in that sense, just in what challenges people face, what their living situations might be like, different aspects like that, until you kind of go and visit the communities and get to know them and just talk with people, find out what their situations really are that you just don't know. So I think it was pretty eye-opening.
During my time, it was a really interesting period in the, I guess, the healthcare scene in Powell. The hospital, there's only one hospital in town, and they're going through a tough financial time. They had previously 6 family physicians who were in their clinic at the hospital, and in just, I think, over 6 months, they'd lost 3 of them. 2 of them started a new practice in town, which there had been no private practices before that, and then one of them was only practicing as a hospitalist. And so they're all getting, they're getting super overworked. They were getting, stressed out. So the guy I was with, he was one of them. He was very busy, pretty frustrated, kind of negative, but real. And kind of what Laura shared about with her III. My project had to do with kind of just educating the community on different healthcare, I guess, primary care models that are found in Powell that had just opened up with this new practice and kind of opening people's eyes to what is available. But it really revealed to me just some of the challenges that are just specific to small towns. This hospital is juggling a lot of different things to keep its doors open, and that's a really vital part of that community. And so I think growing up there, you're just like the hospital's down the street. It just is there. They don't have to work that hard to keep the doors open. That's a total lie. And a lot of rural hospitals are facing new challenges, and will continue to do so. And so I think that was just really good for me to know that that's not an easy task sometimes in different economic situations that certain hospitals find themselves in. So
Great. So I'd like to invite all of you, if you have any questions, if you want to step up to the microphone and ask the students questions. We can probably spend a few more minutes with this particular panel before we switch panels of students, if you guys have any burning questions for the students.
One thing that I did not hear mentioned in the summary, and I'm curious about, is when do you put the gross anatomy lab in? I assume there was a gross anatomy lab for many med students this year. There has been in the past. I missed the first session because I didn't sign up on Facebook, but I'm assuming there was a gross anatomy lab. So when do you get it in this new redesigned medical school program?
Yeah, so I might try to answer that question, you guys. So the next panel of students could actually speak a little bit more to that, but in the new curriculum, students actually do anatomy throughout that 18 months. And for this panel of students, you guys probably did anatomy slightly differently, because I know Galen probably blocked anatomy at the beginning of medical school. Why don't you guys just briefly talk about your anatomy experience?
yeah, so the first, I believe 4 or 5 weeks of my medical school was all anatomy. Then I had a couple weeks before the end of my first semester, and then another, I think 4 weeks maybe after in my second semester, about like that.
We did, in the Seattle campus, which was where I did my first year, we did basically a 5-week gross anatomy intensive where it was the only thing we did, and we were there for hours a day. And it was actually kind of amazing. It was like boot camp, and everybody was in scrubs, and you didn't know what anybody looked like with, their hair done or anything. Everyone was kind of thrown into this difficult, like none of us had ever done anything like this before, regardless of your undergraduate experience. So it was kind of bonding. And then the only other time that we really had gross anatomy with specimens was neuro, where we got to see sections of brain and spinal cord and things like that.
We also did a little bit of musculoskeletal anatomy winter quarter.
That's right.
So.
And Alex, it was probably similar for you, I
Similar,
imagine.
Yeah. It was a blocked setup, and kind of throughout that first year, but mostly it was kind of a boot camp style intensive towards the beginning, and then again with musculoskeletal and neuro.
Kind of sad to see it go.
And we'll make sure to ask the next panel of students that same question, since their anatomy experience will be different than this particular group of students. Go ahead.
Yeah, so listening to people talk about, the number of doctors and clinics available in the rural and also the underserved, I wonder, is there financial assistance? Are there scholarships or maybe help paying off loans for doctors who go to rural places or underserved places?
So do you guys have thoughts on what you're going to do as far as paying for your student loans? And Galen, do you want to start, or you guys can?
Yeah, sure. So I guess a big part of it for me is, and this varies for each WWAMI state, but for me, we actually have a contract with our state, and so a big portion of my tuition is paid through the University of Wyoming, with a little, asterisk that says, if you come back for 3 years when you're done to practice. If you don't, you'll have I signed this, I gotta remember, I think it was a $350,000 loan plus interest that you owe in 8 years if you don't come back. So I think that might have something to do with those percentages you saw with students coming back, with Wyoming on the top, but we don't have very many residency opportunities in Wyoming, which I think is not helpful. But so that's I guess that's where I'm going for a little while, or well, probably forever. But.
Go ahead, Alex.
Yeah, and there are other programs available as well. There are federal programs that are involving the National Health Service Corps, as well as state-run programs. So Washington State has a program that will pay back an annual amount based on kind of how much you're working and if you're in a qualified site. And I think the DOH kind of ranks different sites throughout Washington, as well as the federal government kind of ranks them depending on how much need there is in specific areas. So that varies greatly. And we saw some really nice maps that showed physicians per 100,000 population, which is a really great way to look at things in urban centers. But when you actually look at rural places, sometimes that looks inflated, at least to my eye initially, because there aren't 170 doctors in Jefferson County. I think there's only 27,000 people, and so I think I've met most of the doctors in Jefferson County just from my time there. So, there are certain counties that don't have hospitals, or certain counties where, they may have a critical access hospital that's limited to a very small number of beds, but they might not have facilities like even a ventilator for basic life support. So there are real challenges, and I think getting people out there is very important, and looking at how we can make that happen, I think, with the cost of education is pretty important.
So we have time for maybe one quick question if you want to ask him, and then we'll switch panels. So go ahead.
I was just wondering if you could talk a little more about some of the unique challenges that you face when serving rural and underserved populations, other than lack of resources.
Such a big one, other than lack of resources. I mean, besides what some of the other panelists have talked about, part of the problem with a small community is that, like Paul said, you don't really go home. Like if there's one grocery store, you will run into every patient you've seen in the grocery store. And so, in our introduction to clinical medicine class, some of those topics came up of, how do you handle that, as a doctor, and what can you bring up or not. But I, even in just my 4 weeks in my RUAP site, I had the great opportunity to go to a community dinner, which is like a monthly dinner the tribe puts on and feeds everybody, and they have giveaways and honor elders, and it was a really exciting experience for me. But it was hard to just one night of seeing like, oh, I know that person, I saw that person, and like, do I smile at them? Do I wave? Should anyone know that I know them? That sort of weird social interaction was definitely challenging, and I thought it wouldn't be such a big deal, but it really harkened back to that very first quarter of medical school, talking about what it's like to have a relationship outside of the clinic with your patients, and that is just magnified a lot in a tiny community.
Guys, anybody else have an answer to that or anything you want to add?
I don't know if it's considered a resource or not, but just the challenge of working with patients and not having specific specialties. I don't know if you consider that like a resource. It's maybe a physician resource, but so in Port Townsend, there was no psychiatrist when I was there in the county, and so that's a challenge when you need certain things, or a lot of other specialties just are not there. So then there's kind of an access to care where can your patient afford, or can they spend the time to travel 5 hours or whatever to get to that care, which ends up being really kind of a whole day or two. So
help me thank this particular panel of students for participating tonight. Now we're going to get started with our second student panel. So this panel is actually a group of first-year students who are all here in Seattle. So they're going to talk a little bit about their experience with the new curriculum, realizing, of course, that they're just a little bit almost at the end of Block 3. So they haven't done the whole entire new curriculum, but they're getting there. So I'm just going to have you guys introduce yourselves, tell us where you're from, and tell us why you wanted to go to medical school. So go ahead, James. We'll have you start.
Hi, so my name is James. I'm originally from Portland, Oregon, and I really got interested in healthcare and health equity in college. I went to college in San Diego and spent a lot of time across the border in Tijuana, and there sort of encountered a lot of health equity issues and became really passionate about global health. And so from there, decided to go to medical school.
My name is Rona. I grew up in Vancouver, Washington. And I guess this is the typical answer, but I was interested in science, wanted to help people, and I definitely knew that I wanted a job where I could interact with a lot of different people and get to know a lot of different people, like patients. So.
I'm Aubriana, and actually medicine was kind of nowhere in my differential when I was younger. I went to undergrad at Michigan and majored in economics, and I worked in finance. And it was kind of, I took a break from the banking world and did a study in Brazil that was a combined kind of economics and public health research study. And I saw just an incredibly different way of interacting with people that was very different from a financial private world that I thought was much more of something that I wanted to dedicate my life to. So working with patients became my focus and brought me to medicine.
My name's Emma, and I grew up in Connecticut. And I became an EMT in high school. Went into college thinking that I was going to go into medicine, and then sort of discovered the world of public health and worked in public health for a number of years, and then realized that I just really missed working with people. And so then I got back on the medicine track. So.
Great, so thanks. So now we're just going to go down the line again here with this next question. So you guys knew coming in that you were going to be starting a new curriculum. So maybe just comment on what you thought about coming someplace where you were going to be starting a brand new curriculum. And then tell me what you think now. Like, if there was something you were super excited about, has that turned out to be true? If there was something that you were a little worried about, are you not worried about it now? Go ahead, James.
Yeah, so I think one idea I had about going into medical school is a lot of what you hear is that your first 2 years are primarily spent in a classroom learning heavily academic material that you'll never really need to know again, that you have to know for a boards exam, and then you can pretty much forget, and you'll relearn all the new material when you do your clerkships in 3rd and 4th year. So I would say if one thing has surprised me or that I've been grateful for in the new curriculum, it's been, although there is still some of that kind of basic science foundational material that may not be as clinically relevant, and a large part I think there's been a strong effort to integrate things more from a clinical perspective.
I guess, yeah, when I got in, I was definitely worried about sort of uncharted waters, being a type A medical student, worried about what the curriculum would mean for boards and stuff. But what I always heard from my friends in medical school was that the amount of support that you get, so how much your professors care about you, how much your counselors care about you, and I guess that definitely still holds true so much, especially with the new curriculum. We can tell that our professors care so much about our feedback and what we think of it, and how we're doing, and we have great counselors who also are there for us to hear feedback about the new curriculum, and that's been really great.
One of the things I was looking forward to most here at UW was the primary care curriculum when we get to spend every other Wednesday in a primary care clinic, because I really wanted to kind of get in there and get hands-on right away, and that's actually been even more beneficial, I think, to not only my education, but also kind of getting to know myself in the world of medicine and understanding kind of the social dynamic that goes on in a clinic. And there have been days actually where we learn about a topic in class on Tuesday, and then on Wednesday I see a patient with that exact thing that happened just this block where we were learning about the heart, and the next day in clinic we had to cardiovert someone in clinic, and I was like, I have flashcards on those drugs, you know, like this is amazing. So it's been even kind of a better experience than I even imagined.
Yeah, I think I want to echo some of the stuff that's been talked about, the clinical part of the curriculum. I think it's been a real lifeline for me in terms of going into medical school. I went in with the idea that I was just going to have to survive the first 2 years and sort of get through however I could. And then once the clinical stuff came, it would sort of like make more sense for me as a full human again. And so having that stuff integrated, like being in hospital every other week, being at PCP every other week, and then I'm also a trust student, so going out to my trust site periodically has just been huge in terms of keeping me in touch with why I'm doing this in the first place.
So as part of our new curriculum, we had you guys do that 2-week immersion back at the very beginning of medical school. So if you guys could each just kind of comment on what that was like for you. So you guys hadn't done really any classroom work yet, but we were teaching you how to do a history and physical exam and having you guys interact with patients and other people in your class. So maybe give us a couple of thoughts just on what that immersion experience was like for you at the beginning of medical school.
Well, it really was medical school boot camp in a lot of ways, because we went through a lot of material that you would normally learn like over the course of a year about kind of basic patient interviewing skills really quickly. But I think I came out of it feeling like I was in medical school for sure. Like I had been to the hospital and interviewed 2 patients, and even though I didn't necessarily know what I was listening for, when I was listening to someone's heart and lungs, I knew where I should be listening. And so it was like a start.
One of the aspects that was great about it was how quickly we got close to your classmates. We had to do an activity called Living Anatomy. You kind of drew on each other with markers, and that definitely brought everyone together. And I remember the PCP experience that they're talking about, where you go to a primary care clinic. I had my first one, I think one of the first 2 weeks of school, and I had only done immersion basically, but it was amazing to see how much more I feel like I got out of shadowing, even just after learning what are the parts of a history and a physical, and then getting to watch that versus shadowing when I was just a pre-med. It was really amazing how interesting something just like watching someone do a physical exam for a cough could become.
I think the immersion experience kind of speaks to the level of support that the faculty gives our kind of burgeoning skill and knowledge and independence, because when they were teaching us the physical exam, I thought like, you know, I don't know what I'm doing. And, you know, I'm not sure why they're taking so much time to introduce me to, you know, what I thought was an advanced level of medicine that I didn't know anything about yet. I thought, maybe I'm not ready for this. Maybe I don't even deserve like this level of education so soon. But looking back, I realized that, I mean, they trust that, you know, we can handle this, and the more practice we get, the better. And now I feel like, yeah, like I do deserve that, and it is great to get that right away. And I think it definitely speaks to when you give someone kind of the space to grow, like they'll totally grow, and I think we have.
Yeah, I would echo a lot of what you guys just said. I think it was amazing because it set the tone for the whole curriculum in terms of how important all the clinical stuff is, just sort of putting that up front and investing a lot of time in it was awesome. It makes it so that if getting that whole physical exam at the start, you just see it so many more times throughout the year that you just know it that much better. Yeah.
So Emma, we'll start with you this time, so James doesn't always have to be on the hot seat. The way you guys are doing class now is a lot different than what we had previously. So previously, you know, students would come to class, lecture for 6 to 8 hours a day, and you'd go home and study. And now with the active learning that you guys need to do in class, you guys have to do some preparation before you come to class. So I guess kind of two components or things you guys might comment on about that. One, was that a big transition for you or not? And then two, how do you find that you have to study now to be ready for class or to get ready for your assessments that happen?
Yeah, I would say it was a big transition in that I had been out of school for a while. Thinking back to my undergrad, I took a lot of small, like, discussion-based classes where you did have to do some prep, but definitely no science classes that were like this. So that was a big transition. And in terms of how I study, it's always hard to, we were sort of talking about this a little bit beforehand, and it's hard because we don't really know what the curriculum was like beforehand. We haven't lived that, so I can't speak to how different it is. But I think one of the great things about this curriculum is that if everything works as planned and you have enough time, you see stuff like at least 2, if not 3 times. Like you see it once in your material at home, then you see it again in lecture, and you might see it again in a small group if depending on the block. Yeah, I think I've definitely had to become much more self-motivated about managing my time because there's just a huge amount of material. And you do have to fit it up, make sure you fit it all in on your own time, as opposed to just being able to go to lecture and know that you're going to get everything there. So.
Yeah, I had 5 years or 6 years in between undergrad and medical school, so I kind of had to like put my big girl pants on and like manage my own schedule in between undergrad and medical school, which has actually transitioned really well because I've had to already become best friends with the library, and that kind of self-accountability and self-agency has worked well. And I think it's great that we're doing that now because this is just the beginning of us having to direct our own learning, you know, whether it's outside of a clinic or studying for more board exams or whatever. I mean, we're gonna have to be balancing our own schedule so much moving forward. So this is good practice. And also I love the active learning because I don't know if it's because I'm like an adult student or if it's just like a personality thing, but being able to talk through, like, this is what I'm thinking, like, are you seeing the same thing? Or that kind of thinking out loud with other people is awesome. And I hope that will just keep translating into like a clinical practice when we're working through things together.
I definitely echo what they said about how great active learning has been. I guess in contrast to them, I only took 1 year off between undergrad and medical school, and during undergrad, if I'm being honest, I was definitely give me a book, tell me what to know, I will know it, and I'll go take the test. And I'm a very visual learner, so I was never a big lecture person, but definitely after a few weeks of medical school, I quickly learned sort of how much more my education could be supplemented by having discussions with classmates and discussions in class. And now especially we get small groups, so it's groups of 10 people with one leader, and that has been awesome, and I'm finding that I'm getting so much more out of it than I really ever felt that I've ever gone out of class, just from my learning style.
Yeah, I think I also really enjoy sort of getting to see what all of your colleagues bring to the table because you spend so much time in conversation, and so I think in different times, in different blocks, you've seen people who maybe had a lot of experience in the past with a certain topic or who just are really passionate about it and have learned a lot about it, are able to come in and teach other classmates about it, and you kind of get to see them shine and see what they bring to the table too.
Great. So there was one question that we asked the previous student panel, which was about anatomy and their experience with anatomy. So previously anatomy was blocked. So students did anatomy in a short period of time. So do you guys want to just comment on anatomy since you guys now are doing anatomy a little bit more longitudinally? And I don't know if you guys all want to say something or if you guys all have the same thoughts, but fire away on anatomy.
Yeah, I think having the anatomy integrated with the blocks is great in theory, and I think a lot of times it works out really well. Like it was amazing to have like a bunch of concentrated heart anatomy and then go into the cardiac block and really have it all really fresh. That was awesome. Every once in a while I feel like they'll throw in like anatomy of the inner ear when we're not learning anything else related to it. And I think that can be kind of tricky because there's some stuff that just doesn't automatically fit in with some of the other like bigger curriculum blocks. But I think, I mean, yeah, I don't know, it's hard because I know other students speak really highly of the previous, like having all the anatomy together in a block, and we don't really know what that was like. But so far I like having it integrated.
Yeah, I've been thinking a lot about this, and I thought the thing I've noticed about anatomy, if it seems like its own animal. Like for me, at least, I had to learn how to learn anatomy, if that makes any sense. There's not a lot of other times in my life where I've had to make a three-dimensional map of something, and that's so necessary for anatomy, you know, like what's above the liver, what's below the uterus or whatever. So I think I kind of am craving maybe something that's like more concentrated in the beginning of an anatomy course to kind of get us introduced to navigating a three-dimensional, complex, integrated body, and then revisiting it as we go along in the systems. I think it's great to have it integrated because you can't talk about the heart without knowing its anatomy, but there's also a component of learning how to learn the topic that I think would be helpful.
Yeah, I agree with a lot of what they said. Part of me just thinks, thank goodness we don't have to be in the room with the formaldehyde for 8 hours a day anymore. That is like a major perk in itself. And just speaking of, I definitely feel the same where it took me a little bit to sort of get the hang of anatomy and yeah, learning how to learn anatomy. And the experiences of, you know, classes after us might be different, but it was really cool to see our class and going into our first pin test where they just put pins into your cadaver and you just tell them what that one gray thing is next to the other gray thing. But it was, and so the first pin test, everyone came out feeling kind of shaky, but it was awesome that by the second pin test, everyone was like, you know, we're gonna make our own practice pins, and you know, everyone named something on their cadaver and labeled it and had the answers. And then I went in on like a Saturday afternoon and saw like 10 other people, and we just went through our cadavers. And it'll be interesting to see how each class sort of adapts to the curriculum. But I agree a bit in that it took a little bit to get the hang of, yeah.
Yeah, I think one thing that has been interesting to see how the anatomy faculty have adapted to all the changes, because one of the challenges with our curriculum is that we have a lot of feedback and a lot of things that maybe didn't go so well the first time around that we would say, oh, next time you teach this, you should do it this way. And so in some ways, I think we're all a little jealous of the E2016 class because they'll get all the benefits of the new curriculum plus some of the initial kinks worked out. But anatomy is longitudinal, and so the anatomy faculty has been really great about saying, well, we know in the first block when we tried this, this, and this, it didn't work. So when we come back and do anatomy again in a few weeks, we're gonna try and do this or add this. They've been really great about trying to adapt to that. So I think the anatomy, as we continue to learn it, gets better and better.
So what other questions do you guys have for these students about the new curriculum or what they're doing right now in medical school? Because we have a little bit of time for a few more questions for them. Yeah, thanks for going to the microphone.
Well, thank you, and hey, your enthusiasm is infectious. Thank you. But I guess my question is, all of you going into med school must have had some pre-passion, some preconceived notion about what you wanted to be 4, 6, 7 years later. Is that preconceived notion encouraged? Is it squelched? Is it, you know, what does the first year of boot camp do to the passion that you had coming into medical school?
Good question. You want to start? We don't always have to start with Jameson.
I guess in terms of kind of a preconceived passion, were you talking about like in terms of subspecialty, like what we wanted to do in medicine, or, okay. So given my previous experience, I was kind of already thinking about primary care, and if anything, I've been surprised at how much I actually do indeed like primary care. I mean, the boot camp, I'm not sure if that like swayed me either way in terms of fulfilling or discouraging my passion or anything like that. I mean, maybe it made me feel less confident about my own abilities, but I think the curriculum, the primary care integration is just, for me, has been critical because it showed me like, yes, I really do want to sit alone in a room with a patient. And I really do want more time with them. Like, I really do want to spend more time than we have, you know, when the attending comes in. Like, I have that privilege right now, and I hope that doesn't get taken away. But so I think in that way, it's maybe only kind of stoked my interest in clinical medicine, especially this human side. Like, if you're going in to medicine because you want to connect with someone and help them in their most vulnerable times, like, that is true. Like, so if anything, it's validated that.
I guess in contrast to Aubriana, I didn't really have a clear idea of what specialty I wanted to go into. And it's almost kind of great that other people do, because the people who are into ortho are going to do the ortho interest group, and they'll organize a panel, and I get to go sit in and listen. And then they get more excited about their specialty, and I get to go to a bunch of panels and listen to people talk about what they do. And so our class is great in that we do have that diversity, so I think there really is a place for everyone. Mm-hmm.
James or Emma?
I would say, I mean, I went in thinking primary care, and that's still what I'm thinking, and I'm in the trust program, which has been amazing in terms of sort of helping to support that interest. And PCP has been, like the primary care practicum has been amazing for keeping that going. I think I've heard some interesting feedback from some of my classmates who are pretty sure that they don't want to do primary care, who I maybe feel like they have to do a little bit of extra legwork than previous years did in order to get experience in subspecialties that they're interested in. And I don't know if that's actually true or not, or if that's just they feel like they're spending a lot of time in primary care when that's not where they want to be. And I think I see the benefit of everyone spending time in a primary care office and love that it's part of it, but I think that's an interesting other side to it.
Yeah, I think if I had to like say on day one what I was definitely going to go into, I would have said pediatrics. And so my PCP clinic is, I spend the mornings with a pediatrician, and if I've learned one thing in my first kind of time there, it's that I don't want to be a pediatrician, which I'm really grateful for, like being able to say that early on, and I still really enjoy going and spending that time with him and seeing, we often joke that like if you can learn clinical skills on a kid while they're screaming and their younger siblings running circles around you, then like you can also do those on an adult, and so it's a good learning environment for that in a lot of ways. But I think it's been helpful for me to like early on sort of refocus where I thought I was going, and then open up to exploring different opportunities.
All right, we can probably do one more question.
So thank you. You know, one of the big differences in medical school today, and I think you, Suzanne, Jenny, and I, in our generation, we mastered a body of knowledge, which we then applied on a case-by-case basis. What we're trying, I think, nowadays to do is to change that paradigm so that you know how to access knowledge on a just-in-time, real-time, continuous nature. You're not trying to master the body of knowledge because the body of knowledge is exponentially bigger than when we were in medical school. So can you talk a little bit about how you approach knowledge that you would apply to an individual patient? Is it what you walk in the door with, in the room with a patient, or where are you going for that knowledge?
So I would say that what I've learned in medical school so far is that if I'm approaching a patient, or even if I'm approaching a body of research, or even just one paper, is that I should be curious. That kind of a summary of knowledge that I've taken into this situation is definitely valuable, but it's not the end-all be-all, and I definitely will never know everything, right? So I've definitely learned kind of to create like a comfortable curiosity, like where I can ask questions of the patient, like, can you clarify that? Or what does that mean to you? And instead of saying, this is my idea of nephrotic syndrome, and so that is what they have. So I think there's more shades of gray, and that requires a more open mind, for sure.
Yeah, I think, I mean, it's a tough question. I think at this point, what my college mentor, so every other week we go into the hospital with an attending, and 2 of us interview patients. And what she always says is she's always amazed at how our clinical skills are way beyond our knowledge. Like we can sort of like walk through the motions and like not really know all the reasons why yet. But I think it's, I mean, the body of knowledge is just massive, and to some extent, I think you know, even though we know particularly little right now, you're never going to know everything. But the amazing thing about having those interactions with patients is that once they like act as hooks to like hang knowledge on. So once you see a patient who has something, you can sort of be like, oh, okay, like there's where I'm going to hang those things. Now I'm going to remember, you know, all the skin signs I'm supposed to look for bacterial endocarditis, for example, which I learned on Monday. So, yeah. Yeah.
I think that's all true. I think when I was growing up, my dad would always say, you know, the more you know that you don't know. And I think medical school, that has definitely made me realize how much I don't know. And I have said to some of our older lecturers, like, it's so unfair. When you guys were in medical school, everything fit into a book, you know, that thick. But he said, yeah, but you guys have iPhones. And so I think that's definitely true. Even in my primary care clinic, it's interesting how acceptable it's become for my mentor to be like, okay, you know, talking to the patient, like, I'm gonna pull up my phone and look this up. And I think it makes the patient feel good too, to know that they're getting sort of the most up-to-date information about any sort of illness. And a lot of our mentors, I think, have set good examples on, even in class, saying, hey, this is what you need to know for the boards, but this is actually a paper that came out last month, so keep an eye out, it might change.
Yeah, I think it's really challenging to kind of be faced with how little you understand. And as a part of our sort of hospital morning program, the first term, my group was here at UW, and so often patients we saw were here because multiple other doctors, maybe even specialists, didn't know what was going on, and so they referred them here, and eventually found they were treated with a high-level team that was an expert at managing this sort of rare condition. And so often we'd be interviewing someone who we definitely didn't know what was going on, and often our mentor also didn't necessarily know what was going on, and so we would learn from the patient about what their condition was. But I think one experience I've also had is recognizing that there's no feeling more gratifying than taking that sort of like, I have no idea what's going on, or we're not really sure, and converting that into like, we do think we know what it is, and here's how we're gonna proceed. And I got to do that with a patient in my primary care practicum who had sort of confusing symptoms that didn't really line up to any clear picture right away. And then we sort of learned about a condition that sounded like it in class, and then I did some research online and sent it all to my mentor, and now she's like getting the relevant test to that, and we think that's probably what it is. And so I think through that kind of like first quest, it was recognizing that like, as tough it is to be faced with all the stuff you don't know, it's also really exciting to have resources at your fingertips to dive deep into that and get to be a part of like figuring things like that out.
So please help me thank the students for being here tonight to talk with us. Thank you.
So I don't know if this is working. Can I borrow your microphone? I'm not mic'd out. Thank you all for coming. We have certificates for those of you who, as Jenny said, have been to a number of these with signatures, so you can frame them. We look forward to seeing you next year. Please come and have some cake with us and punch in the back. I think it's out in the hallway. And again, thank you for your great support for making Many Medical School 2016 such a great success.
Thank you all.